The LMLR is an annual event that we do. And this is the 17th year in honor of the first Filipino rheumatologist, Dr. Lourdes Manahan. And this is a quite special because it is also Dr. Manahan's 100th birth anniversary. Dr. Manahan was a special woman of her time. In the 1950s, she pioneered the field of rheumatology in the Philippines. She established the section of rheumatology of the Department of Medicine of UPPGH in 1971, and next year will be its 50th year as both a training and service arm of the Department of Medicine of PGH. Around half of the country's 155 rheumatologists graduated from its training program. At this point, from across the globe, in El Paso, Texas, I am happy to introduce our special guest, Dr. Rosario Nadora. She was the first fellow of the Rheumatology Training Program of UPPGH. After her training here, she went on for research fellowship in the University of Connecticut and fellowship training in rheumatology in Loyola University Hines VA Hospital in Illinois. The first part of her career in internal medicine and rheumatology was spent in Williamson Memorial Hospital in West Virginia, where she became the chair of the Department of Medicine. However, she transferred to Texas, where she actively practiced up until last year. Let me now call on Dr. Nadora.
Well, thank you, Evelyn. Good afternoon, everyone. I am happy to be here and appreciate the opportunity to share my thoughts and reflections on Dr. Manahan. My mentorship with Dr. Manahan spanned only a total of 2.5 years, from January 1980 to mid-1982. But in terms of her impact on my formation as a physician, it feels like a lifetime. In the early 80s, rheumatology was a young field, and much of what was going on was in research, particularly in immunology, molecular biology, and genetics, which was a handicap since, as you know, research is an expensive undertaking. Still yet, with her networking skills and collaboration with her international colleagues, Dr. Manahan was able to keep pace with the newest advances in rheumatology at the time. Like a true mentor to me, Dr. Manahan always encouraged me to seek further higher training. And she actually, with her networking skills, got me a research fellowship with Dr. Naomi Rothfield at the University of Connecticut, who was at the time at the forefront of lupus research. It was an excellent program, but I quickly realized that bench research was not in my blood and that I am basically a clinician at heart. Looking back, I think this was what Dr. Manahan actually wanted for me, to find out for myself what kind of physician, rheumatologist I wanted to be. So long story short, I went through another 3 years of internal medicine residency and then 2 years of rheumatology fellowship. And from then on, forged my own career path and have been perfectly happy and fulfilled. Through the years, Dr. Manahan and I kept in touch through exchange of birthday cards. And whenever I would visit the Philippines and she would come and visit her relatives in the States, we would always meet. And in at least one serendipitous meeting at the ACR meeting in San Antonio. which brings me to my final point. Um, I think Dr. Manahan is the true definition of a mentor. And I looked up the definition of a mentor once, and it is this. A mentor is an experienced and trusted advisor who shares information of his or her own career path, as well as provide guidance, motivation, emotional support, and role modeling. I think she checks all of those boxes. Thank you.
Thank you. Thank you, Dr. Nadora, for sharing your experiences with Dr. Manahan as a mentor. These help us bring her and her examples to life. It is heartwarming that you are able to join us today. Thank you very much.
Thank you.
I would also like to thank our sponsor, Astellas Pharma Philippines Incorporated, for making this webinar possible, and to all our participants, you, for attending. This webinar focuses on the management of gout, the second most common arthritis among Filipino adults. Our speaker is Dr. Angeline Therese Magbitang Santiago. She teaches in the UP College of Medicine and is the training officer of the Rheumatology Fellowship Program. She is an active clinician and researcher and is also deeply interested in health informatics. On top of that, she is also an accomplished 21K runner, a singer, and a musician as well. Let us now listen to Dr. Santiago's lecture on the holistic management of gout. Dr. Santiago?
Thank you very much, Dr. Evelyn, for that kind and very nice introduction. Um, it is truly nerve-wracking, yet a huge privilege to give a lecture in honor of Dr. Lourdes Manahan. And today, my topic is the holistic care for patients with gout. Okay, wait. Can you see my lecture already? Okay. Okay. Okay, holistic care for patients with gout. So when I was given this lecture topic, I was initially struck by the term holistic care, and I wondered what exactly does that mean? So my knee-jerk instinct was simply to talk about the pharmacologic and non-pharmacologic management of gout. But on further reading and introspection, I realized that holistic care has a deeper meaning and includes factors affecting the delivery of care to our gout patients. Hence, I came up with these objectives for today's lecture. And these are to review the updates on the diagnosis and management of gout, to discuss the factors and barriers affecting the care of gout. Okay. But before we do that, let's review the basic pathogenesis of gouty arthritis, because this is something that we really need to understand and we need our patients to understand. As what Dr. Evelyn said, gout is one of the most common inflammatory arthritis affecting adults worldwide. And central to its pathogenesis is hyperuricemia and the deposition of uric acid crystals. So uric crystal deposition in tissue starts to occur when the serum uric acid level rises above the normal threshold, which is defined as 6.8 milligrams per deciliter. And this can occur due to overproduction of uric acid by excess intake of dietary purine, from endogenous purine synthesis, such as in cases where there is an underlying malignancy or underlying conditions like tumor lysis syndrome or even conditions like psoriasis. deficiencies or abnormalities in the enzymes that are involved in purine salvage and purine breakdown, as well as under excretion of your uric acid. And the excretion of uric acid occurs mostly in the kidneys, and one third of excretion occurs in the gastrointestinal tract. So an imbalance between the production and excretion can lead to your hyperuricemia and eventual deposition of uric acid crystals, leading to gout. Okay. These deposition of uric acid crystals in the joint is the triggering cause of your painful arthritis. They initiate the inflammatory process by being engulfed by the synovial phagocytic cells, leading to the release of lysosomal enzymes and production of inflammatory chemokines, which leads to inflammation and subsequent tissue injury. But it is more than a joint problem. This is something that we have to understand. The disease burden of gout extends beyond the development of extremely painful arthritis. In fact, it has been well established that gout is associated with cardiovascular, metabolic, and renal dysfunction, as well as increased mortality. In this large cohort, a survey, the National Health and Nutrition Education Survey of more than 5,000 adult gout patients in the United States, majority of our gout patients had concomitant hypertension, renal impairment, and obesity, as well as other conditions such as diabetes, nephrolithiasis, myocardial infarction, heart failure, and stroke. And this goes beyond the production of uric acid, but the chronic inflammation that these uric crystals elicit in the body. Okay. So established gout, and particularly complicated gout, is also associated with increased mortality. And as shown in this longitudinal study of 706 patients with gout, majority of deaths were attributable to cardiovascular cause. So gout in itself increases the risk of cardiovascular disease, renal disease, as well as mortality. Hence, before we proceed further, I think we should all realize that gout is not just a disease affecting the musculoskeletal system. In fact, it is a disease that can affect the heart, the vasculature, your kidneys, and even cause increased mortality. This is something that we must emphasize to our patients because it will have an impact on their compliance, on their follow-up, and in their long-term prognosis and management. So let's go to the management of gout. And I'd like to do this by starting with a clinical case of Mr. LBJ. Mr. LBJ is a 35-year-old male who presented to us with a 2-day history of extremely painful and swollen right knee, which happened after he partied and drank when he won a basketball tournament. And he disclosed that he had similar episodes in the past involving the right big toe and ankle 3 months ago, and this was relieved by the intake of naproxen. It didn't work this time. The patient did not show any symptom or sign of infection, but on examination, the right knee was warm, swollen, tender, and limited in range of motion. The patient was overweight and had a blood pressure of 160 over 100, although he is not a known hypertensive. So the next question is, what would be the most important diagnostic test to be done for this patient? So you can answer in your hearts. And if you answered C, then you are correct. Let me explain this further by showing to you this 2018 EULAR guidelines. And this is the most recent set of guidelines on the diagnosis of gout. And it emphasizes the need to make a definitive diagnosis of gout, ideally by demonstration of your urate crystals, or if not possible, by clinical features that strongly suggest gout with the use of imaging tests, if the diagnosis is uncertain. Why do we need to prove our diagnosis of gout? Well, essentially because we have a lot of different arthritides that can mimic gout. Like in this picture, this inflammation here can easily be caused by other crystal arthropathies like your calcium pyrophosphate deposition disease or pseudogout, or it can be due to an infection like cellulitis. In this picture here of an inflamed digits of the feet, um, this is actually a case of dactylitis secondary to psoriatic arthritis. The Heberden's nodes and Bouchard's nodes of osteoarthritis can sometimes be mistaken for tophi, and even the inflammation of rheumatoid arthritis can sometimes present acutely and be mistaken for gout. So it's really important to establish this diagnosis to give appropriate management. So in the diagnosis of gout, definite diagnosis involves demonstration of your monosodium urate crystals by polarizing microscopy, and they appear as your needle-shaped, negatively birefringent crystals. However, it is not always possible to do synovial fluid aspiration or arthrocentesis. And the guidelines recommend that you still can make a clinical diagnosis of gout based on features that are suggestive or highly typical of gout. I have given a mnemonic of crap me because you'll definitely feel like crap if you have a gout attack. And these features include concomitant cardiovascular disease, an arthritis that is very rapid in onset and very severe, involvement of a monoarticular arthritis, acute arthritis of the joints of the feet, particularly the metatarsophalangeal joint and your ankle, history of previous attack, male gender, the presence of overlying skin erythema, and hyperuricemia. So if you have those clinical features, then the diagnosis of gout can be likely. Imaging tests can also be used when crystal identification is not possible and clinical diagnosis is uncertain. And these imaging tests include X-ray or radiographs, and the classic features include your bony erosions with overhanging edges and a sclerotic rim. You can also sometimes see tophi, and this is seen here as this enlarged area in the metatarsophalangeal joint of the left foot. However, these features are already seen in advanced gout and can be missing in the early stages of gout. Another imaging test is your ultrasound, which can see your uric acid crystal deposits as tophi or as the classic our pathognomonic ultrasound feature of the double contour sign. These are the two hyperechoic areas that you can see here. So you can use these imaging tests to supplement your diagnosis of gout. Okay. Another thing that we have to remember when we are treating our gout patients would be to assess for the presence of risk factors for chronic hyperuricemia, such as the presence of renal disease, obesity, the intake of certain medicines that can increase uric acid, such as your thiazide diuretics, your low-dose aspirin, and even your chemotherapeutic drugs like your cyclosporin and in your immunomodulator tacrolimus. These medicines can act as drugs that can increase uric acid, as well as diet, assess for excess alcohol, the intake of non-diet sodas or high purine intake, and associated comorbidities as discussed earlier. Why? Because they can contribute to the vital prognosis of gouty patients, and they also complicate management. So going back to Mr. LBJ, an arthrocentesis was performed on his right knee, and this yielded the classic monosodium urate crystals on your synovial fluid. And the good thing about this procedure is that we were also able to rule out concomitant infection, as it did not show any organism on synovial fluid culture. The uric acid was elevated, and the patient has normal creatinine clearance, lipid profile, and sugars. So we can now definitely say that this patient, LBJ, has acute gouty arthritis and probably also has hypertension. Now, how do we manage Mr. LBJ? Okay, so these are the two largest guidelines, the latest guidelines on the management of gout. One coming from EULAR in 2016, and just this year from the American College of Rheumatology. And both guidelines agree on the recommendation that our first-line treatment options include your colchicine, NSAIDs, or steroids, or it can also be a combination of your colchicine plus NSAIDs or steroids, depending on the severity and the number of joints involved. Ice compress can also be helpful during the acute attack, as it may reduce the symptoms of inflammation and may lessen the duration of attack. Colchicine is now given at a low dose because of the AGREE trial, which compared giving colchicine at a low dose versus high dose. And they demonstrated that low dose colchicine is as efficacious as high dose colchicine with a significantly lower adverse event profile. So they agree that you need to treat early, ideally within 12 hours from symptoms. And during that time, you can give your colchicine 2 tablets immediately, followed by another tablet after an hour. And then on the subsequent days, you can give it at anti-inflammatory doses of up to 4 tablets per day. Okay. So we said that we need to treat early, and that's another important point that we need to educate our patients on. And this is the concept of pill or medication in pocket. We need to educate our patient on how to treat an acute attack. So it's either by giving them advice on how to apply cold compress, elevating their legs, and the appropriate use of your anti-inflammatory drug. Okay, how do we choose the anti-inflammatory drug to use? The basis for our choice would have to be patient-centered. And you have to factor in the comorbidities, the use of concomitant drugs, patient access, and even past experience. So this is a table that I made to summarize some of the conditions that you need to check in order to help you or to guide you on what you shouldn't give in the following on the choice of your anti-inflammatory agent. For example, colchicine, you don't really want to give this to patients with advanced chronic renal disease or significant liver disease, or those on concomitant P-glycoprotein or CYP3A4 inhibitors, as this may lead to life-threatening or fatal levels of colchicine in the blood. You use NSAIDs or COX-SIBs with caution in patients with chronic renal disease, heart failure, peptic ulcer disease, anticoagulants, and liver disease. You need to be cautious about using oral steroids in your patients with peptic ulcer disease, diabetes, and with concomitant serious infections. IL-1 blocker, such as your anakinra, canakinumab, this is an option in the US and European countries, but this is not yet available here. And it has a potential to induce severe sepsis. Hence, you need to check for infections if you would like to start IL-1 blockers. And this is considered a second-line agent for acute gout attack. So for our patient, Mr. LBJ, this is our acute gout management plan. Okay. The next question would be, should we start urate-lowering therapy for Mr. LBJ? Remember that Mr. LBJ is 35 years old. This is not his first attack. He has been having attacks for the past 3 months. And he's also hypertensive and overweight. So if you answered yes, then you are correct. These are the definite or strong indications for urate lowering therapy initiation. If you have a patient with established gouty arthritis with frequent attacks, meaning he's been having at least 2 flares of arthritis per year, if there is presence of tophi, or if there is urate arthropathy or radiographic damage attributable to gout, then you can definitely start urate lowering therapy. But can we start urate lowering therapy earlier in the disease course of a patient? For example, if the patient comes to you during the first attack of gout, do we really have to wait for patients to have that second attack or to have more frequent attacks? Or do we wait for him to develop tophi? Both the EULAR and ACR say that yes, you can start earlier, particularly in patients with cardiovascular and renal comorbids, or those with very high serum uric acid levels at the time of diagnosis, or if the patient develops gout at an early age. Why? Because there is increasing body of evidence that gout worsens cardiovascular and renal disease and ultimately increases mortality risk, as well as the potential benefit of urate lowering therapy on cardiovascular outcomes and prognosis. So this is a condition, these are conditional recommendations. And again, this will be a shared decision between you and your patient. Okay, so what are our urate lowering therapy options? We have your xanthine oxidase inhibitors like allopurinol and its metabolite oxypurinol, as well as febuxostat. And you have your uricosurics. Unfortunately, probenecid and benzbromarone are not available here, as well as the new player lesinurad. We have losartan, and these drugs act on our main URAT1 transporter. They inhibit URAT1 transporter, which promotes renal, which has a uricosuric effect or promotes renal excretion of uric acid. So our first line treatment for gout is still allopurinol at a dose of 100 milligrams or even lower for patients with renal disease to a maximum dose of 800 milligrams per day. We have another choice of urate lowering therapy or xanthine oxidase inhibitor, which is febuxostat, which can be given at 40 to 80 milligrams per day. And it can be used in patients with mild to moderate renal impairment with no dose adjustment. Uricosurics can be given in combination with your xanthine oxidase inhibitors in patients who do not respond to your first-line treatment. So important concepts in urate lowering therapy. So this one is something that we have to remember. We need to start at a low dose and titrate slowly. Why? Because number one, if you start at a high dose, the sudden shifts, the sudden dramatic shifts in uric acid can actually precipitate a flare. Number two, there is a higher risk of developing adverse events with a higher initial dose of urate lowering therapy, such as renal impairment or liver function problems, and even your hypersensitivity reactions. So to avoid that, it is best to just start at a low dose and titrate slowly. We need to treat to target. Remember these numbers. This is something that you will need to instill in your patients. If you have a patient with uncomplicated gout, then you can target a level of less than 6 milligrams per deciliter. So you need to achieve and maintain that level. For tophaceous gout patients, our target is less than 5 milligrams per deciliter in order to promote faster dissolution of because they have a higher burden of uric acid in the first place, and you want to promote faster dissolution of tophaceous deposits. Again, the treatment of your urate lowering therapy should be given long term. It takes years for your uric acid crystals to form, and by giving it for just 1 week, 2 weeks, or even a month, you are not able to dissolve the urate crystals that have formed over the past years. It is important to emphasize this to your patients. There is a small case control study, I think, that tried to see if we can discontinue urate lowering therapy in patients with gout in clinical remission. And they found that in the next 5 years, only 17%, a very small, only a small portion of those patients, even with a low uric acid level, did not suffer a flare, meaning majority of patients, even when they were already on clinical remission, when they stopped their urate lowering therapy, there was a higher risk of developing flare thereafter. So the current recommendation is still to give it long term. And together with your long-term urate lowering therapy, you need to give your colchicine prophylaxis for the first 3 to 6 months to prevent flares during the time when we are trying to dissolve your uric acid crystals, or if or colchicine is continued until there is the presence of your tophaceous deposit. Okay. Okay. There is a dilemma or a question of, can we start urate lowering therapy during a gout attack? Diba? The traditional way of starting allopurinol or febuxostat is that we wait for the flare to subside, and then we start the patient on urate lowering therapy after 2 weeks, 2 or 3 weeks, because there is some evidence in observational studies that if you give urate lowering therapy during an attack, it can worsen or prolong the duration of flare. However, there will be some instances wherein maybe you'd like to start, for example, in patients that live in far-flung areas who will not probably follow up with you, or those who have tophaceous deposits and have been untreated for the longest time. And maybe because these patients, symptomatic patients, they say are more highly motivated to start urate lowering therapy. So in the 2020 ACR guidelines, they gave a conditional recommendation that you can start urate lowering therapy during a gout attack together with your anti-inflammatory medication based on 2 small studies. So this is a small study of only 57 patients with acute gout who were randomized to allopurinol 300 milligrams daily or matching placebo at day 1 of attack together with NSAID and colchicine. And as you can see in the graph, it did not show a significant difference in the pain score and subsequent flares during the course of the study. This is another small study of 31 patients who were given allopurinol 100 milligrams or placebo during an acute attack. And again, there wasn't a significant difference in terms of the pain score during the course of the gout flare and the disease. So, I sorry. So I think the message here is that you should still individualize treatment, and there will still be cases that you may start urate lowering therapy during a flare. And again, you have to discuss the risks and benefits with your patient. So approximately 2% of our patients on allopurinol will develop this highly fatal condition of severe cutaneous adverse drug reactions. So this is a case report of a patient who developed Stevens-Johnson syndrome after receiving allopurinol. And patients who are at increased risk for this condition are those with concomitant renal or cardiovascular disease, those who were started on high doses initially, and those with genetic polymorphism of HLA-B 5801 allele. And this is commonly seen in your patients of Southeast Asian descent and African American descent. Therefore, the guidelines recommend that HLA-B 5801 testing be done prior to allopurinol in patients of Southeast Asian descent and African American patients. There is some issue regarding the cardiovascular safety of febuxostat. Hence, the black box warning from the FDA released last 2018. And this is based on the FDA commissioned CARES randomized controlled trial. But that trial did not have a placebo control group, and the increased risk of cardiovascular disease was seen in the secondary endpoint analysis and not in the primary endpoint analysis. There are other observational studies showing that febuxostat can actually have a protective effect in terms of cardiovascular disease. So I think we still need to wait for further details. There is an upcoming study result coming out, the FAST trial, and this one, we are waiting for this in the next few months. And this will tell us if, this will help us determine if indeed febuxostat should not be given to patients with cardiovascular disease. Your uric acid should not be given to patients with known renal calculi or moderate to severe chronic kidney disease, as this may worsen the renal impairment. So aside from treating the acute flare and giving urate lowering treatment, as we said earlier, gout is more than just a joint disease. We need to screen and treat your comorbidities. For concomitant hypertension, there is evidence that losartan and calcium channel blockers have uricosuric effects. So it has an additional benefit to your gout. So if your patient can be safely switched to these medications, then you can do so. As well as fenofibrate and statin for patients with hyperlipidemia. They also have uricosuric effects. Patients with diabetes mellitus should be treated appropriately. There is increasing evidence that SGLT2 inhibitors can also have beneficial effect on uric acid. For patients on diuretics, hopefully we can maintain them at minimal effective dose. And again, like we said, if your patient has renal impairment, you need to give a lower initial dose of allopurinol, usually at 50 milligrams per day, and you titrate slowly. And another option would be to give febuxostat. Patients who are obese should be advised to adopt a weight loss program. You should also stop other factors that increase your cardiovascular risks, such as smoking and excessive alcoholic beverage intake. So there is also an increasing evidence that ULT has cardiovascular and renal benefit independent of its effects on gout. There are studies showing that it can help lower blood pressure, as well as inflammation seen in your chronic cardiovascular diseases. So this is an area of research. This is an interesting area because maybe in the future we can use our urate lowering therapy not just to treat gout, but also to augment our management of cardiovascular and renal diseases. So this is our treatment plan for Mr. LBJ. So I plan to start him on allopurinol at 100 milligrams per day, together with colchicine prophylaxis, and probably start him on losartan for his hypertension. I will probably follow up Mr. LBJ every 2 to 4 weeks to check on his BP, uric acid, renal and liver function. Oh, that's liver. And I will adjust the dose of allopurinol accordingly based on the serum uric acid in order to achieve and maintain our target of less than 6 milligrams per deciliter. Okay, educate, educate, educate. That's the most important thing I think that we need to remember when we are dealing with gout patients. We need to educate them not just on medications, but also on their disease. Essentially what happens in gout patients and what is the expected course and why it is important to continue treatment, the effect of the disease on other comorbid conditions, and very important also to discuss diet and lifestyle as well as weight management. In general, um, the advice that we give our patients, as guided by evidence and guidelines, would be to limit alcoholic beverages, particularly beer, as heavy drinking or binge drinking is actually associated with gout flare. And abstaining from alcohol can lower your serum uric acid level by at least 1.6 milligrams per deciliter. So that's one of the advice that you can give your patients. Avoid binge alcoholic drinking or limit your alcoholic beverage intake. Another thing that we can advise our patient would be to limit purine intake, particularly from animal sources. So this is a study that evaluates the risk of gout attacks with increasing amount of purine intake. And as you increase the amount of purine that you consume, you can see that the risk of developing gout flares also increase. So there's a dose dependent relationship. And this is significantly seen in food that is from animal sources compared to plant sources. So in general, we try to advise our patients to limit their intake of beef and other red meat. Okay. What about high fructose corn syrup? So this is a component of most of your Western diet. Um, your high fructose corn syrup is present in almost all usual. It's very ubiquitous in our diet nowadays. And why? Because it's cheap and it contains 55% fructose and 45% glucose. However, it promotes uric acid formation by utilizing ATP. It promotes degradation of ATP, which leads to the formation of your adenosine monophosphate, which is a precursor for your uric acid. So we need to advise our patients to limit high intake of high fructose corn syrup, as it is associated with a higher risk of incident gout and can increase your uric acid level by at least 1 to 2 milligrams per deciliter. So those are the general advice that we give our patients. So this is a nice meta-analysis that was published in the British Medical Journal in 2018. And I know you can't really read this, but I'll walk you through it. The purple bars represent food groups that have uric, that increases uric acid levels, while the yellow bars represent food groups that actually reduce serum uric acid levels. And they found, and this one, the topmost item here is beer. And they found that there are 7 food groups associated with raised serum uric acid levels. And these include beer, liquor, wine, potato, poultry, soft drinks, and meat. While your eggs, peanuts, so hindi bawal ang mani, cold cereal, skim milk, cheese, brown bread, margarine, and non-citrus fruits are actually protective. But what is interesting to me about this meta-analysis is that they also compared the contribution of diet to genome-wide single nucleotide variations. And they found that diet only explained less than 0.3% of variance in serum urate compared to 23.9% of variance in serum urate levels compared to your genome-wide single nucleotide variation. So this highlights the fact that really diet plays a plays a significant role, albeit a small one or a secondary role, in the pathogenesis of gout and even in the occurrence of gout flares. What is important is that our patients comply with medications. We have to tell them that diet is something that they can improve on, but it is not something that they can solely rely on, because there are other factors that can promote or precipitate gout attacks. Okay, kasi sometimes the patients blame themselves and they get depressed and they even lose their motivation to seek treatment because they will say, ayan, babawalan na naman akong kumain ni doktora. So we have to let them know that diet plays a role, but it's actually a secondary role and there are other factors. So we should refrain from blaming our patients, diba? Okay. So another thing that we have to educate them on is weight management, as obesity is associated with incident gout. In fact, an increase in BMI of more than 5% gives a 60% higher odds of recurrent flare, while decreasing your BMI of at least 5% will lower your odds of recurrent flare by 40%. And if you lose weight of at least 5 kilograms, you can lower your serum uric acid level by 1.1 milligrams. Okay. Okay. So gout is very common. In fact, gout patients are seen not just by rheumatologists, but also by general practitioners, internists, family medicine doctors, even orthopedic surgeons. So this is something that we commonly encounter. And I think as individuals, we know at least one family member with gout. But despite being a common disease and despite the advances in the management of gout, the advances in knowledge, the treatment of gout remains suboptimal. And one of the reasons for this would be poor adherence among our patients. So this is a nice study in Israel, done in Israel on more than 7,644 adult gout patients. And they noted, so the dark black bars here represent the proportion of patients with poor or partial adherence. And you can see that they outnumber those patients who were adherent to their treatment. And the mean duration of therapy until it was discontinued was only 358 days for males and 379 days for females. So more or less after a year of treatment, your patients will discontinue their urate lowering therapy. So sayang, di ba? Because this is a disease that can be managed effectively. And this is because there are several factors affecting the care of gout. And these factors include your patient's perception about their illness, the practitioner's professional knowledge and perception, and even the societal perceptions of gout. They all act as important determinants of the decision for your patient to seek and continue treatment. And what current data are telling us is that there are still significant gaps in knowledge about gout and its treatment, not just in our patients, but also in practitioners, healthcare providers, and even in our society. And this is our goal. We need to identify and bridge the gaps in knowledge and gout. For our trainees who are listening, this is a nice research agenda for you because we still lack published Filipino data on factors that affect the care of gout among Filipino patients. And the gaps, we need to identify the current gaps in knowledge. Okay. So how can we improve disease education in people with gout? We need to improve education because we want to give optimal gout patient outcomes. And it is seen in studies that effective gout patient education is integral to achieving this. Effective gout education should be interactive and patient-centered. You should explore or address the knowledge gaps, match modality with patient preference. Kasi ngayon, it's not just the traditional, the patient goes to your clinic and then you just tell the patient what to do. we have so many modalities that are available to us. We can utilize published materials, or even online learning materials, or even group, ano ba yun? Group, parang group work, study groups, or even support groups that can help with their continuing education. So we need to instruct in the basic principles. Basically, what we have been discussing for the past minutes. We include the family and caregiver, and you factor in the socioeconomic factors, the race of your patient, the education of your patient, the age of your patient. So you have to tailor your education to your patient. So you need to individualize it. And I think this is super important. Education should be ongoing and spaced. So meaning it's not just a one-time thing. It shouldn't be just on the first consult. Every time your patient follows up, and even in between, you need to try to continue with that education. Okay? So a multidisciplinary approach is also something that we can look into. In fact, the 2020 ACR guidelines already recommend that nurse-led and pharmacist-led interventions be applied in order to optimize the adjustment of your urate lowering therapy to achieve your target uric acid level. So as we pivot towards universal health care, this is something that maybe we can incorporate also. And then use opportunities in hospital and urgent care settings to plan long-term treatment approach. So I'm nearing the end of my lecture. In essence, what should we tell our gout patients? Basically, what we've discussed for the past hour. So the causes and consequences, what happens when you have your urate crystal deposition, the risk factors for hyperuricemia, and the associated comorbidities. And finally, the appropriate treatment. Okay. And for the key points, before we all go to our Q&A, I think these are the things that I want you to remember. When dealing with gout patients, prove your diagnosis, consider and treat your comorbidities and risk factors, manage acute flares early and appropriately, empower your patients to manage their attacks on their own, the proper use of urate lowering therapy if needed. So it is given long-term, you start low and go slowly, you treat the target, and you give anti-inflammatory prophylaxis for 3 to 6 months or longer to prevent flares while you treat. And again, an interactive and patient-centered, individualized, ongoing, and multidisciplinary patient education. So thank you very much for listening.
Okay, thank you, Dr. Ange. Please join me as we answer the Q&A. We have a lot of very interesting questions. Many of them are clarifications. One of them is about cold compress. So how long and how frequently should we give cold compress during an acute attack? Ange?
Okay. So cold compress can be applied for at least 15 to 30 minutes, and it can be given 3 times a day, as long as the patient is able to tolerate it.
Okay. You mentioned about the pill in pocket and empowering our patients, but some of our patients use prednisone. Is that a good pill in the pocket?
No, definitely not. This is when education will really, you need to step up your education of your patient, because we know that prednisone should not be taken parang there, it should be used judiciously, and it can be prone to abuse. It can be prone to misuse, and it is associated with a lot of adverse effects. So this is something. Kaya, ma'am, yung steroid actually, if I don't know. Kung ako, ma'am, hindi ko siguro i-advise yon unless you need to educate unless it's a super educated patient and you need to really tell this patient that ito yung mga possible side effects. Ganun, ma'am. Usually, ang modalities for pill in the pocket would be colchicine, and even yung non-pharmacologic modalities like application of ice, rest, elevation of your affected extremity. Ganun, ma'am.
So in still about the acute attack of gout, in places where they do not have rheumatologists, you mentioned about intra-articular steroids. Is there any
Yes,
replacement
ma'am.
for that?
Okay, so intra-articular steroid, uh, is usually reserved for patients who have, kunyari, monoarticular arthritis of the right knee, and meron siyang synovial fluid or with a large effusion that you need to aspirate, and you know that there's no infection. In gout naman kasi, your other anti-inflammatory agents can still work, such as if it's really a severe flare and you cannot do an intra-articular injection, then you can do combination treatment with colchicine or NSAID if with no contraindications. Or sometimes you can also give systemic steroids such as intramuscular or intravenous steroid for a short duration of time. Yun, ma'am. Because I understand that not everyone can perform or not really confident to perform an arthrocentesis or synovial knee injection or joint injection.
Okay, so I guess what you're saying is that for acute gouty arthritis, our options are colchicine, NSAIDs. We can give steroids. It can be oral, it can be intramuscular or intravenous, or it can be intraarticular. But the
Yes.
decision will really be based on many things. You were mentioning about renal failure, the renal function, past experience. So those experiences, the patient's renal function, can guide us in our choice uh, in acute attack.
Yes, ma'am. That's
Okay,
correct.
so there were quite a few who asked about how long term, how long is long term when you're talking of urate lowering therapy, and how do we choose between febuxostat and allopurinol, and are there adverse effects with long-term use of these drugs, including long-term use of colchicine?
Okay. So when we say long term in terms of urate lowering therapy, um, we mean long term. Meaning, kasi wala pa talagang there is really no strong evidence that you can stop it and your gout will not recur. In fact, I relayed to you the study on this group of patients that were able to achieve clinical remission and with very low uric acid levels already, and they stopped their urate lowering therapy as per study protocol, but during the follow-up period, only 17% were flare-free, meaning there was still an increased risk of flares after the urate lowering therapy was stopped, even in patients who have already achieved clinical remission. Because we have to understand that the uric acid deposition process is something that is affected by genetics, aside from your diet. So baka talagang kailangan, it's like it's like you're treating hypertension or diabetes, diba? So it's long term is really chronic therapy. And in terms of adverse events, that this is where your regular follow up comes in, because indeed you have to watch out for side effects in the kidneys and even your liver. Uh, so this is where your follow up will come in. And ano pa ba? How do you choose between allopurinol or febuxostat? Again, this will be based on the presence of concomitant disease, comorbidities. Um, if you have a patient, they are the studies say that both drugs have equal efficacy. So it will really be dependent on the safety profile of that drug.
What about colchicine? How long should we give colchicine?
Yes, ma'am. So colchicine, this is your anti-inflammatory prophylaxis because when you start urate lowering therapy in gout patients, you have an increased risk of flare, particularly in the first 3 to 6 months as your uric acid burden is still high. So the recommendation is to continue colchicine for at least 3 to 6 months or until you're able to achieve your target serum uric acid level and flares are not occurring anymore. But if you have a patient with tophaceous gout, then you need to continue your colchicine prophylaxis until your patient has tophi, because it means that that patient still has a high uric acid burden and will still have an increased risk of developing flares. So, yun lang.
And I think you mentioned that for people with tophi, our target serum uric acid is a little bit lower. No,
Yes.
so it's not 6 milligrams per deciliter, but actually
Five.
5. So for patients with tophi, there were a lot who asked, do the tophi still dissolve, and how long do you usually have to treat them before we see dissolution of this tophi?
Yes. Yes, they do. The tophi can dissolve. In fact, but it will take a long time. You don't expect your tophi to dissolve in 1 month. No, it will actually take years for your tophi to dissolve because it also took many years for your tophi to form. The important thing is to let your patient know this so that your patient will be on board with your plan to titrate the medicine so that he can achieve the low serum uric acid level. And eventually, if the patient is able to maintain that, then dissolution of tophus can occur. I actually have mama patient had really hard tophi along his olecranon and the knee. But after around 2 or 3 years of regular follow-up and urate lowering treatment, the tophi also has already decreased in size and has already softened. So it can still improve. May
Okay.
pag-asa, ma'am.
Oo. Yeah, I also see that. But unfortunately, for patients whose tophi have dissolved, if they start the urate lowering therapy, then the tophi can also come back. I've seen that happen. So we really need to educate our patients. Can we combine prednisone and allopurinol during the acute attack? Because well, I know this is a bit of controversy. Some rheumatologists do not agree that we start the urate lowering therapy during the acute attack. And you were talking about a study showing that you can. And
Yes.
the question really is that can we combine prednisone and allopurinol during an acute attack of gout?
Okay. Um, like what I discussed earlier, the traditional way really and the safer way I think would really be to wait it out. to wait for the gout flare to resolve. After 2 weeks, you can start your urate lowering therapy. But there will be instances wherein you would like to start urate lowering therapy immediately. And yes, I think you can still combine it with prednisone. However, the caveat is that these studies are small. The first study that I showed only had 57 patients. And the second study only had 31 patients. So I don't think we can really get a good conclusion based on the two data. We need further studies to establish if we can really give urate lowering therapy during an acute attack, or even with prednisone or your other anti-inflammatory medication.
Okay, so another very interesting question here is that when we start our urate lowering therapy, when would be a good time to check your uric acid level again?
Okay. The recommendation is to check after around 2 to 4 weeks. Yan, ma'am. So you ask the
Okay.
patient to follow up and see if your urate level is responding. And then you can adjust the dose of your urate lowering therapy on follow-up if the patient still hasn't achieved the target serum uric acid level, and if there are no contraindications to increasing the dose.
Okay. What about patients with gout who already have lost weight? You know, they're exercising, they are maintaining a good diet, they are taking their medicines, for example, is already on febuxostat, and previously has not had attacks, like last attack was 6 months ago, and then starts to have uh, an attack every 2 weeks. What should we look for? What are we missing here?
Okay, so this patient already has normal weight, tama ba ma'am? Normal weight.
So
So
the weight has gone down.
okay. So maybe you have to check if there are other factors, such as maybe this patient is not drinking enough fluids, or maybe there is an ongoing condition that can be triggering that gout attack, such as infection, or even maybe the use of concomitant medications. Or you also have to check if this patient is really able to achieve the target serum uric acid level. You have to look for what is causing this trigger in your patient. Parang ganun, ma'am.
Yeah, that's true. Just to share, I had a patient with tophaceous gout who started having attacks again because he ran out of colchicine.
Ah,
So,
yes, ma'am.
yeah, that has been a recent problem.
Yes.
So, I think very important is that we look for an underlying cause. Sometimes maybe the patient started a new drug which can increase the uric acid. So we look for all of these things. You
Yes, ma'am.
mentioned losartan being beneficial in having a urate lowering therapy effects. Can you also, are there other ARBs which are also beneficial?
Unfortunately, ma'am, the uricosuric effect is unique to losartan. And the other ARBs in several studies did not show the same benefit that losartan um, exhibited in terms of urate lowering. Another option would be to use calcium channel blockers, which can also um, can help lower your uric acid by having a uricosuric effect.
Can exercise increase uric acid?
Exercise. You mean acutely?
Aerobic exercises,
Aerobic
things you do in
exercises.
the gym.
Yeah. Well, not exercise per se, but for example, if you did not drink adequate water, or if you do not stay hydrated during your exercise session, then you can increase your uric acid level, because dehydration can actually stimulate your sodium transporter in the renal tubule, and this will promote uric, together with sodium reabsorption, this will promote uric acid reabsorption. So that's one of the reasons why dehydration can actually cause a gout flare or a spike in your uric acid level. So it's not exercise per se, I think. But another factor, I guess, would be if you injure yourself during an exercise. Sometimes if you suffer a sprain or a strain, if there are tophaceous deposits in that joint, then you can precipitate a gout flare.
Okay, so there are several questions here about gout and existing comorbidities. So, in patients with advanced CKD with gout, should colchicine not be started at all, or should it be given in renally adjusted dose? And what treatment plan can be given for CKD patients? So, I guess this is for the acute arthritis.
For the acute arthritis, and the patient has CKD and is suffering from an acute attack, maybe colchicine will not be a good option, because you can't really give it at an anti-inflammatory dose, diba? You can, colchicine is not really renally dialysable, so you have to look for other options to give to your patient, such as maybe steroids. You can give it
Mhm.
intraarticularly or short course systemic steroids. Sometimes we can still use colchicine as prophylaxis, but at very reduced doses, depending on the kidney function. Sometimes you can give it as low as once a week. Yeah, but you can use other options. But sometimes if you have CKD already, then you have other comorbidities that will prevent you from using NSAIDs or even steroids if you have diabetes. So, mahirap.
Maybe we can have one or two more questions. Thank you to our audience for your very nice and interesting questions. There is a question here about guidelines on asymptomatic hyperuricemia. What are the latest? Do we really need to give urate lowering therapy for asymptomatic hyperuricemia? And one other question that maybe we can link with that, is there a relationship between high sugar and hyperuricemia?
So to answer the first question, asymptomatic hyperuricemia is not automatically treated with urate lowering therapy. Why? Because longitudinal studies have shown that even in patients who have asymptomatic hyperuricemia, the risk of developing gout is not that high. No? Kasi there are other factors pa rin. The recent guidelines do not advocate the use of urate lowering therapy outright. Rather, what you need to do would be to screen for risks of chronic uric acid elevations and to screen for comorbidities that might be causing that uric acid elevation, and you need to address those factors. There is also some evidence that the use of allopurinol, for example, in patients with asymptomatic hyperuricemia, there is a risk of developing adverse events. You need to weigh the benefit versus the risks kasi. So, wala kasi siyang strong evidence that it can prevent the formation of gout. So, it's still better to thoroughly assess your patient for comorbidities and other risk factors that might be causing it, and addressing those factors first. As to Sweetened, ano nga ba yung tanong, ma'am? Sugar?
High sugar and
High sugar.
hyperuricemia. Yeah.
Yes, there is a strong connection between high sugar intake and hyperuricemia. As I said earlier, di ba, yung mga sugar-sweetened beverages can acutely increase your uric acid levels and has also been seen to be associated with incident gout and even gout flares. Why? Because it promotes ATP degradation in the liver, which leads to your formation of AMP, which is a precursor for your purines and subsequently uric acid. So it promotes uric acid formation. And aside from that, if you have a high sugar intake, then you increase your risk of other diseases that are associated with gout, such as obesity, diabetes. So there is a strong link between high sugar intake and hyperuricemia, as well as metabolic syndrome and hyperuricemia.
Okay, and for our last question for this afternoon, from Dr. Saulog, allopurinol has a lot of drug interactions and most older patients are already on a lot of medications. So for me, it's not first line in patients on polypharmacy. Is this correct?
Okay, not a first line. Okay, so yeah, it's hard to treat patients, especially if you have concomitant multiple concomitant comorbidities. That's why you have the option of starting other xanthine oxidase inhibitors like febuxostat, especially if you have a patient who already has renal impairment and you cannot give allopurinol. So it's the decision to the guidelines are just there to really guide us, but of course the treatment should still always be individual. Should involve a shared decision making between you and your patient.
Okay, thank you, Dr. Santiago, for answering all of those beautiful questions. I am sure our audience learned a lot from you today, and thank you everyone for asking these questions. So this afternoon, we learned how to diagnose and treat gout, which is not only an arthritis, but can be considered a systemic metabolic disease that can increase mortality. Dr. Santiago gave us facts on how little or how much diet affects the serum uric acid, and ideal management of gout is long-term and holistic, involving control of other factors and diseases that worsen hyperuricemia. We would like to thank Director Gerardo Legaspi, Dr. Margarita Latluna, and the PGHIT team for making this webinar possible. Our special thanks to our sponsor, Astellas Pharma Philippines Incorporated. Thank you all for joining us, and we hope to see you again on November 11 as we talk about refining the management of osteoarthritis. Have a good gout-free day, everyone.